Good evening, sir. Chintan, sir, shall we start?
અપૂર્વા
હા, yes, sir.
હું ગાડીમાં છું એટલે ચાલુ કરી દો, હું સાંભળી રહ્યો છું.
હા, okay, sir. Sure, okay. Chintan, start.
હા, ચાલુ કરો. જો કોઈ જોઈન થાય 5-1 મિનિટમાં ચાલુ.
Yes, sir. Yes.
Okay.
Good evening, sir.
હા, sir. Okay.
Good evening.
Okay, sir. Thank you, sir. Chintan, start.
Yes. Today's my topic is about the spinal injuries. The anatomy of the spinal cord. The spinal cord starts from the foramen magnum and they extend till the L1 to L2 level of the spine, and it's the conus medullaris. Then it extends as the chorda equina, that is the extension of the nerve root, and it terminates as the phylum terminale. This is the cross section of the spinal cord, which is showing the tracks that are carried from the carries the nerve that carries the nerve from the cerebrum to the respective muscles and the dermatomes. The mode of the spinal injuries. Mostly the spinal injury, isolated spinal injuries are very rare. It is always associated with the came as the polytrauma. The most common mode of the injuries are the road traffic accidents, which are 30%, fall down 30%, physical effort in the form of the gunshot wound either 40%, sports injuries 99%, and the medical or surgical complications. The pathophysiology of the spinal cord injuries are primary or secondary. The primary spinal injury, it is due to the direct assault to the neuronal element that occurs at the time of the injuries. The secondary injury that occurs either due to the hemorrhage, edema, or ischemia to the spinal cord. Hypovolemia, hypoxia may aggravate the secondary injury after the any assault to the spinal injuries. The physical examination. If the patient present with the polytrauma, we have to evaluate the patient like the as the form of the advanced trauma life support principle. We have to maintain airway, breathing, circulation, disability assessment, and the exposure of the environment. But particularly for the spine examination, we have to carry out first the spinal log roll method. In this maneuver, the patient is first in the lying down position.
It is spoken in the exam. If it is asked, it is spinal log. After that, there is no full stop. It is a log roll method. Just like you are rolling the log, wooden log. It is a log roll method. Okay.
As the figure shown in the figure, the rescuer number 1 that is at the end of the head, and the other rescuer are at the side of the patient. The rescuer number 1, which is present at the head, will hold the head and the neck without giving any traction. The rest of all the rescuer will support fix the patient and gently pull the rotate the patient toward their side, along with the rescuer number 1, which has hold the head of the patient. The another person will roll the any wooden material or stretcher, so that we can shift the patient from one side to another side. During this shift, rotating the patient, we have to assess any external injury marks to the spine, like is there any tenderness, swelling, or redness is present or not. Neurological.
So this is a method whenever you are shifting the patient from the road or somewhere else to the stretcher, or from stretcher for any other radiological examination. Whenever you are shifting the patient from one place to other place, you have to shift patient with this loggerel method, right? Okay. Don't lift the patient. That is the protocol in this RTA.
The neurological examination, the neurological to examine the neurological deficit, there is a Freckles classification for the spinal cord injury. There are 5 grades, which is graded as the A, B, C, D, and E, which are applied in the American Spinal Injury Association. In this slide, in this form, they have given, they have indicated this class. The form is given to check the motor function and the sensory function. There are 28 dermatomes which are checked, and the gradings are given according to the their sensation and the motor function. In the sensory function, that include the light touch and the pinprick. The sensory for the sensory assessment, it start from it include 28 dermatome from C2 to S4 to 5. The grade that are given for given are 2 numbers are given for the normal, one for the 1 number for impairment in the sensation, and the 0 number for loss of sensation. Similarly, and the highest total number of the score for the sensory marking are 112. The motor key and the motor sensation, for that, the over the 4 limbs that are assessed for according to the their power, they are graded from 0 to 5 according to the their power and power and the pressure. The
what do you mean by pressure? Power is okay.
The power is
you said pressure. What do you mean by pressure? Motor function is power, and then second is a sensory function. What is pressure? Chintan, are you hearing?
yes, ma'am.
So it is a. Have you written somewhere?
No, ma'am. It's
so it is a misinterpretation. Okay,
yes.
Continue. It is only power.
Yes, ma'am. The elbow flexor, elbow extensor, wrist, finger flexor, and finger abduction are used in the bilateral upper limb, and for the lower limb, hip flexor, knee extensor, ankle dorsiflexion, long toe abduction, and the ankle plantar flexion. These all are used to assess the muscle power. And according to this score, they have divided the scale into the 5 grade A, B, C, D, and E. If there is a complete loss of sensation and the movement which is present in the complete spinal cord injury. In the grade B, there is a absence of the motor function, but the sensation are present. In the type C, The there will motor function will be present, but which is not useful. The sensation is intact. In the grade D is the motor that is completely lost, and the sensation is present. In the grade E, there is a normal function.
No. See, in the C and D part, C is the power is less than 3/5, and the second is power is more than 3/5. So I think
motor is useful, but and the sensation is present, sir.
Yeah, motor is useful.
Useful.
So the paraparesis is there, but still there is some power is there.
Power is present.
Yeah, but sensations are normal. So from B, C, and D, the sensations are almost normal. In B, motor is completely absent. C is the power is less than 3, and D is between 3 to 5, but it is less than 5.
Yes. The spinal injuries are associated any other organ injuries like the spine. If there is a the lumbar spine fracture, it will associated with mostly with the splenic injuries, renal injuries, hepatic injuries, and the small bowel injuries. Sometimes the thoracic spine injuries, if it is present with the compression of the sternum, it may lead to the aortic rupture or the any vascular. It may arise the vascular complications. Diagnostic imaging. The diagnostic imaging of the spinal injuries can be done by the digital radiographs, CT scan, MRI, and the dynamic imaging. But if the patient is mostly present with the polytrauma, we should go for the FAST and the UFG to rule out any solid organ injuries. The specific spinal injuries, the spine that in
whenever you are talking about the FAST, the first assessment is done as for TA is one is head injury. Whenever you are getting any limb motor dysfunction, or if there is a paresis somewhere, then you have to first see for the cervical injury rather than any other spinal injury. So you have to stabilize cervical spine first.
Yes,
right?
Yes,
Okay.
The specific spinal injuries, the upper cervical spine that include the occipital condyle fractures, occipito-atlantal dislocation, atlas fracture, and the odontoid fractures. This is the occipital condyle fracture, atlanto-occipital dislocations, Jefferson fracture, which include which is the fracture of the C1 vertebra. Odontoid fracture, the fracture of the upper border or the process of the C2 vertebra. And the thoracic and the thoracolumbar fractures.
So in cervical spine, whenever you are asking for this X-rays, particularly for the cervical spine, if you are willing to see the first and second vertebra, so X-ray which is taken is open mouth X-ray. So you cannot see from the routine X-ray bilateral film or the AP film the first and second cervical spine. Normally, when we have doubt, we do not do cervical spine. But if any patient who is sent for a patient is coming after a few days and you are suspecting, and if facility is not available for the CT scan, in that case, open mouth X-ray is done, in which you can see first and second cervical spine. Right? Okay.
The thoracic and the thoracolumbar fractures that include the thoracic spine, thoracolumbar spine, and the lumbar spine fractures. The type of the shock that following the spinal trauma. There are three types of shock that occurs in the spinal trauma: are the hypovolemic shock, neurogenic shock, and the spinal shock. Hypovolemic shock, it may be due to the sudden loss of the large amount of volume that may be associated with the any other organ injury, which may be present. May be present with the hypotension, with tachycardia, and the cold chemiperipheries. Second type of shock is the neurogenic shock. This is a special type of spinal shock which present as the hypotension with normal heart rate or the bradycardia with the warm peripheries. It may be it occurs due to the there is complete disruption of the thoracolumbar sympathetic nerves with the medullary cardiovascular system. So there is no sympathetic active supply to the periphery, the arteries. So there will be the dilatation of the vessel occurs. So it leads to the hypertension with the bradycardia, but there will be the normal warm peripheries, which may last for the 24 to 48 hours. Then if the patient goes into the recovery phase, then it will be recover spontaneously, but it may last up till 4 weeks to 6 weeks. Spinal shock, temporary. There is a
how will you differentiate this neurogenic shock from the vasovagal shock when there is a bradycardia? As you have said, it is a warm peripheries in neurogenic shock.
Neurogenic shock.
In vasovagal shock, there will not be a warm periphery. And within few minutes, patient recovers after the vasovagal shock. If it lasts longer, then you think about neurogenic shock and not the vasovagal shock. Okay, continue.
The spinal shock, temporary physiological disorganization of the spinal shock. The function start within the following injury. It can last for the 6 weeks or the long time. The spinal cord injury may be either complete or incomplete. We can assess the if there is a anal tone is present during the bulbocavernous reflex. That means the spinal cord injury is incomplete spinal cord injury. To assess this bulbocavernous reflex, we have to retract the glans penis or retract the pull out the Foley's catheter. It will contract the anal muscle, and the anal tone will normal or raise. So that indicate there is not a complete spinal cord injury. But there are several types of the incomplete spinal cord injury that are the central cord syndrome, Brown-Sequard syndrome.
If patient is fully conscious, and you can do PR examination, and then you ask the patient to this force at the anal region. Then also we can see the anal tone. See, all the patient do not require inserting this Foley's catheter. Right? If patient is unconscious and having quadriparesis and quadriplegia or paraplegia, then you can assess by this inserting the Foley's catheter for the anal tone. Right?
Or yeah, doing a PR will give you a lot of things about the tone of the anal canal, and that's by indirect evidence to any spinal injury.
Yes.
Okay, continue.
Okay. The types of the types of incomplete spinal cord injuries are the central cord syndrome, Brown-Sequard syndrome, anterior spinal syndrome, posterior cord syndrome, and the chordae equina syndrome. In this, the anterior spinal cord syndrome and the posterior cord syndrome are due to the there is ischemia due to their respective arteries. The central cord syndrome. Central cord syndrome that occurs following the hyperextension of the neck. In this type of injury, there is most mostly all the part of the lateral spinothalamic tract, including the gray matter and the white matter, are damaged. So there will be loss of the motor function below the level of the injury, and there will be minimal or no loss of the sensation. Brown-Sequard syndrome.
Wait, wait.
Yes,
Please and repeat. I could not get you. What did you say?
In the central cord syndrome, it will include the gray matter and the white matter and the corticospinal tract. Lateral, mostly the lateral, most of the part of the lateral corticospinal tract. The spinothalamic tract is spared, so the there will be loss of the motor function rather than the sensory functions.
Okay.
Brown-Sequard syndrome, it occurs due to the hemisection of the spinal cord, which in that all the gray matter, white matter, and all the tracts of the one spine of the lateral half of the spinal cord are injured. So there will be the loss of the power in the motor function in the contralateral part, and there will be loss of the sense pain. There will be the loss of the muscle tone at the level of the injury, and the loss of pain and temperature at the contralateral side, and the paralysis, complete paralysis of the ipsilateral side. Can I go further?
Continue.
Yeah, continue. So these syndromes are
So
important.
fibers are crossing.
Crossing,
Fibers are crossing. Anteriorly lying sensory fibers are crossing. See, sensory fibers are lying mainly anterior part of the spinal cord. So they are crossing, and so because of that, contralateral side of sensation will be absent.
The sensation that are carried from the lateral spinothalamic tract that cross at the level of the same level. So from that below that level, there will be the complete loss of the pain and the temperature.
Yes.
Anterior cord syndrome. The anterior cord syndrome occurs due to either there is a compression or there is an infarct following trauma to the anterior vertebral artery. That is only arterial supply to the spinal cord in the anterior aspect. So there will be paralysis of the only anterior aspect of the gray of the tract. We also include the gray matter and the white matter. So there will be loss of the pain and temperature. The motor function will be there will be paralysis of the motor supply, because it also includes the corticospinal tract. But the position and the vibration that are carried out by the spinal tract and the which are present in the posterior aspect and the posterior aspect of the spinal cord. So there is the sparing of the position and a vibration sensation. The anterior cord.
Touch, temperature, and pain is lying anteriorly.
Anteriorly.
So touch, pain, and temperature will be absent, and position and vibration is posteriorly. So it will be absent. It will be preserved. Right?
Patient is able to maintain his gait, his position, but the active movement is absent in anterior cord syndrome. And in the posterior cord syndrome, the complete opposite. Only the posterior aspect of the vertebral spinal cord is damaged. So the posture, the patient will have the all the sensation and the motor function are preserved, but there will be the loss of the position sense, vibration, and the light touch, which occurs due to the there is an infarction in the bilateral posterior vertebral artery or infarction. Coda equina syndrome. Coda equina syndrome occurs due to there is any compression to the below the level of the L1, L2 at the coda equina, where the all the nerve roots only nerve roots are present. So the compression may lead to the there is a pain below the pain only occurs below the level of the iliac bone. Like their patient may be patient will present with the thigh pain, urinary bladder disturbances. Patient may have the sexual dysfunction. Patient may be present also present with the constipation or altered bowel pattern, because there are some nerve that some of the nerve supply that also supply the lower end of the bowel, myenteric plexus of the bowel.
So in a pelvic fracture, but below the L2 spinal fracture, as well as when there is a pelvic fracture which is extending higher up to the sacroiliac joint. So in that case, nerve injury is there, then also patient will have this type of symptoms. Correct?
Yes.
Okay.
The other complications of the spinal cord injury, is first is the pressure ulcer, pain and the spasticity, autonomic dysreflexia, neurological deterioration, and the thromboembolic event. This occurs due to the mainly the patient has no sensation below the level of the transaction or the deformity. As there is no sensation, and there is loss of the blood supply comparatively the normal side. So the chances of the pressure falls are more in the spinal cord injury rather than the other paralytic other paralysis head injury patients.
What is autonomic dysreflexia?
It occurs.
See, we are worried about the autonomic dysreflexia is about, we are worried about the hypertension. See, it is having so many other symptoms also, but particularly whenever patient is having spinal injury, higher up spinal injury starting from the thoracic and the upper lumbar vertebra. So in that case, because of the retroperitoneal hematoma or the mediastinal hematoma, this dysreflexia will occur, and sympathetic system is disturbed, autonomic and sympathetic system, and patient will develop hypertension on 4th day of the injury, the 3rd or 4th day of the injury. So normotensive patient will develop sudden hypertension. It may rise up to the 180, 200 by 110. And so the patient hypertension requires control of the hypertension by giving antihypertensive. And this hypertension lasts for 3 to 4 days, and then patient again become normotensive. So any patient who is having spinal injury should be observed for the hypertension after the 3rd day of the spinal injury. Continue.
Management of the spinal injuries. There are the spinal realignment, stabilization, decompression of the neuronal element, and the corticosteroids.
I think the first thing should be stabilization.
Yes, stabilize.
Most important is stabilization. That is what, so we talk about log roll and cervical collar and all those things, the most important thing, the thing of utmost, because so that in spite of some kind of fracture, there is minimal trauma to the spinal cord, and there is minimal. See, the trauma actually is not the cause. The cause is the edema that develops in the spinal cord. So creates compression syndromes, and all those complications of spinal cord injury are basically because of stress. So as soon as you find, that's what already Madam said, that the first thing you seek after airway and that is circulation, is the cervical spine. Continue.
After the stabilization of a patient, spinal realignment. The spinal realignment are giving by the cervical tongue to give a traction in the to maintain the neutral position, and they relieve the compression over the spinal cord. Other are the braces. The braces are soft and hard collar, Philadelphia collar, and the halo braces.
See, these cervical these prong are used particularly to stabilize the head of the patients. Whenever patient is having quadriparesis or patient fall down from the height. So when patient is fall down from the second and third floor, and you have this history that it is likely that patient may have first and second cervical injury, then traction is given at the cervical spine, and counter traction is managed by keeping the foot end head and elevation and foot end down. So body of the person will be counter traction, and this traction is given at the skull. So that will stabilize first and second cervical vertebra, right? Yes. So by the time you get the CT and cervical spine, CT of the cervical spine and all these things, you have to give the simultaneously cervical collar to stabilize the rest of the vertebra, cervical vertebra. Continue.
The cervical collars. The cervical collars available are the soft and hard collar, Philadelphia collar, and the halo braces. We mostly use the hard collars rather than the soft collars, as the soft collar will restrict only the movement of the flexion and extension of the neck, but the hard collar will additionally give support to the occipital region of the head, so it will give the more stabilization to the head. This is the Philadelphia collar. But now Aspen collar and the Miami collar are more useful, comparatively more useful, as they are,
because these collars are also utilized for doing the tracheostomy.
Tracheostomy.
Also. These patients can be underwent tracheostomy.
The only complication that arises from the cervical collar is there may be increase the intracranial pressure following the vascular occlusion, venous compression to the neck. It may, if there are any signs that indicate there is a rise in intracranial pressure due to the cervical collar, then we have to immediately remove the cervical collars. These are the halo. Halo that is used to stabilize the fracture of the atlanto-occipital fracture, which include the jacket and that circular part over the head, which will restrict the all this movement of the skull. The side movement and the flexion and the extension movement are also restricted. Am I audible, ma'am?
Yeah.
Other part is corticosteroid, but the corticosteroids are the role of the corticosteroids are controversial. Currently, we are giving the methylprednisolone in the bolus form as bolus dose as the 30 mg per kg over 1 hour, and followed by the 5 mg per kg for 23 hours. But there is no definite evidence that this corticosteroid can reduce the damage to the cervical spinal cord. It is useful in the compression due to the malignancy or any tumor.
And it is also helpful, particularly if there is a edema. When there is a edema because of the sudden hyperextension and sudden trauma and due to the injury to the cervical spine or any part of the spine. So because of that, if there is a edema is reduced, and so it is given as a routine in all the paraplegia consultant, by the paraplegia consultant. So it
As
is
an empiric,
used,
it might not
still
use,
it is
definitely
used.
there is a definitely use.
It is also available as a Dexona shock pack, and if patient comes immediately within 1 hour, you can give the hydrocortisone 200 milligrams straight also. So that is for the emergency. Hydrocortisone is having short actions, but in emergency you can give it as an emergency, and after that it should be continue with this. Okay.
So, Chintan, what is the importance of spinal injury in abdomen?
What will you apply? The spinal injury of the lumbar spine.
Sir,
Yeah.
mostly the spinal injuries with the lumbar, if the lumbar spinal injuries will mostly associated with the blunt abdominal trauma. So there will be solid organ injuries like liver, spleen, and the chances of a bowel or even pancreas, laceration of the pancreas may occur. And if there is a loss of if there is a transaction of the spinal cord, the loss of the sensation from the abdominal wall may mask the pain, tenderness, so we can miss the
So two to three things. One is, of course, that severe pain because of spinal fracture you may miss peritonitis, possible. Number one. Number two, at times spinal injury itself can cause severe spasm, and you doubt some kind of bowel injury. Even spinal fractures can lead to large retroperitoneal hematomas, mimicking hemoperitoneum, mimicking what you call guarding in the abdomen rather than rigidity in the abdomen. So both the things are possible. You may miss it, or at times you may falsely consider a spinal injury as a patient of peritonitis. And it is definitely a cause for paralytic ileus.
That is known as a meteorism. If it produces paralytic ileus, it is known as a meteorism. And what you apply is known as an abdominal corset. It is having board at the spinal area, so it will not allow flexion of the spine. Right? So abdominal, it is just like binder, but having the board at the back side. So it is known as abdominal corset. So that is to be applied if there is a lumbar spinal injury. Thoracic spinal injury is usually stabilized because of the patient is having ribs which are not fractured. But if ribs are also fractured and you find out that patient may not maintain it, if there is a flail chest, then there is also, as you shown in previously, you can apply that type of protecting sheet on the chest also. Right. Okay.
Thank you. Thank you.
So basically the idea is to not miss the spinal injury during your primary survey. See, as a surgeon, you are very hell-bent upon looking into the abdomen, as we have already said, but the first thing you need to look is to look for the cervical spine, stabilize the cervical spine before going for abdomen. Once you've examined the abdomen, you see to it that the other spine, that is the dorsal as well as the lumbar spine, are normal. Look for any abnormal movements, especially with no fractures. You should definitely look for any immobile, upper limb or lower limb, unilateral, bilateral, or on one side, whatever. And plus the bladder and bowel. Bladder and bowel in the initial phase may be difficult, but then, as madam has already said, that PR examination from spine point of view is also important. Say, if some injury is there, you can definitely diagnose it by the tone of the anal canal.
Chintan, that photograph of how to assess the spinal injury, as you show in, I think, third or fourth slide. This is excellent. This one. This is excellent. You get printout of 10 such photographs.
Yes.
So we will keep in the board. So every first year should know for assessing the which level spinal injury is there. So get 10 printouts. This is excellent.
तो एक OT में भी लगावी देजे ना?
Yes, sir.
In trauma center and OT. Good.
OT, yes, definitely.
Yeah, this is excellent.
Good,
It is a
good.
speedy assessment of this level of spinal injury. Good one.
Thank you.
Okay.
Thank
Fine.
you. Thank you, sir. Thank you, sir.